Welcome to the Growing Rural podcast, where we focus on all things rural in South Carolina. We will discuss topics on healthcare, economy, education, and the unique culture that is our rural state. This podcast is supported by the South Carolina Center for Rural and Primary Health Care. Please join us for today's topic.
Hello, everyone. Welcome back to the Growing Rural podcast. I'm your host, Dr. Kevin Bennett. Our guests today are Julie Smithwick and Romaine Stevens. Julie is the director of the Center for Community Health Alignment here in Columbia. Romaine is a community health worker with the South Carolina Office of Rural Health and a community health worker ambassador for the state. So welcome, Julie and Romaine.
Thank you.
So I'll start with you, Julie. Tell us a little bit about your center and how you got into doing this work that you're doing.
Thanks for having us this morning. The Center for Community Health Alignment is part of the University of South Carolina Arnold School of Public Health, and our mission is to co-create solutions to advance health equity alongside communities. So I'll tell you a little bit about what that means. First of all, I got into this work because I lived in Ecuador, South America, for about 4.5 years after my college days, and one of the reasons that I stayed so long is because the first couple of years I was there working with very impoverished communities that were under-resourced, is that a lot of the things that I would try to do failed and didn't stick, and communities weren't receptive and didn't show up. And I kept, hitting my head against the wall and saying, why is this not working? And finally, I started listening to folks, right? Mm-hmm. I was trying to input into the communities my solutions and what I thought was right for them. Right. And what I realized was that for something to really work, communities need to be engaged. And in fact, communities need to be the decision makers in the communities. They know what their strengths are. Communities know what their challenges are, and they know what a lot of the solutions are.
Right. They know what's going to work.
Exactly. Yeah. So I became a community health worker. I was trained in Ecuador as a community health worker. I learned some skills that for community health workers are essential. Building trust with communities, building from people's assets, starting from where a family is and what they know is important to them, and helping to coach them and build the resources and skills they need to address their own problems from their point of view. And the central component of starting with communities and really looking at communities as assets and folks that have the power, I'll correct that. They don't always have the power, right, or the resources, but they have the ideas and the strengths and the assets they need to really address their own challenges. So that's really what the Center for Community Health Alignment partners with folks to do.
Trying to get them over the edge, so to speak. Give
them
that little push
and be that bridge between. So we've got resources in our state, like state government. We've got fantastic universities. We've got funders. We've got a great public health system, healthcare systems, and then we've got a lot of communities out there that need support and resources. Right. Some a whole lot more than others. When we talk about equity, right? Equity means that different communities have different resources and different people based on like where they were born, who their parents are, how much financial resources they have access to, et cetera. What kind of environmental, social issues their communities face or don't face. People are on that equity scale or somewhere, right? But a lot of times, folks who want to support those communities that face more inequities kind of come into those communities and want to help, right? And want to share those resources and give those ideas and those programs. But again, going back to my experience in Ecuador, those programs and those solutions are not going to work and not be effective if we don't start from where the people are, right, and their ideas and the leaders in that community.
Right. And so you came back to the States after that experience, obviously, because you're here now. And then what? You started the center whole cloth, or was it incremental?
Yeah, so I came back to the States. I taught school for a couple years with immigrants. And again, I taught English as a second language and was working with the immigrant population because I was bilingual and bicultural at that point. Spoke fluent Spanish and had spent a lot of time in Latin America. And the same idea, right? Like seeing that even within the school system, folks were struggling with like, how do we get these parents involved? You know, the parents aren't showing up. And some folks would even say they must not care about their kids' education. And me being in the middle, I would talk to the parents, and the parents would say, no, of course, that's why we're here. You know, that we do, of course, care about our kids' education, but we don't have access. When we go there, they don't speak our language, or we don't know how it works. And so I got in the middle and said, okay, well, let me start a program where I can help the parents learn how the school system works, right, and become more engaged. And so all of these ideas continued to percolate, got my master's in social work, and had some relationships here at the State Department of Health in South Carolina. And at that time, it just so happened that the Hispanic population in our state, the Latino population, was growing really rapidly, especially the birth and fertility rate. So the State Health Department, Division of Perinatal Systems, asked me to do some research on like, what does this population need? How can we help meet their needs? So I did that research, presented it, and was offered a little bit of funding. And when I say little, like this much, the person actually said, I can pay you part-time for 6 months to start something to help this population. So jumped in and did it. And that's where the organization PASOS that I started was formed in 2005.
Okay.
So that was kind of the next step. And PASOS, from the very beginning, based on these experiences I had, we started with the community health worker model. I said, you know what? When I lived in Ecuador, when I worked with immigrant families before, what they said was, we want to make good decisions. We want to have access to the system. We want to advocate for ourselves. Sometimes we just need somebody that we can trust to walk by our side and help us do that, and help us learn to advocate for ourselves. So for 14 years, I ran PASOS, and we started a whole network of community health workers that were immigrants themselves, speak Spanish, had that same experience of the folks that they were helping, that can help them connect to resources, learn to advocate for themselves, really build on those strengths and help them connect to the things that they needed to be successful, so that they and their families can really thrive like they want to.
Right. And correct me if I'm wrong, but I believe community health workers, a big component of the model is to draw the workers from the community itself, right?
Exactly. That's the essential component, is that a community health worker be from the community that they're serving, or, like in my case, have spent a long time really working to understand and embrace and really study and learn and be able to build trust with members of that community. Ideally, it's somebody from that community, which is, again, why I'm kind of in this administrative role and a little bit stepped back now, because I know I'm not the most effective person, because I'm not an immigrant, or I'm not somebody from a rural community that can really do that more naturally.
Or a person of color, for example.
Correct. Yep. And so a couple years ago, when I stepped down from the role of PASOS, you brought up person of color. You know, I'd led PASOS for 14 years. And at that time, we had, after that time, we had a whole team of incredible community health worker leaders. And I stepped back and said, you know what? I'm not Latina. I don't need to be leading this organization anymore. It's time for the community to lead itself. They don't need me anymore. So I stepped down. Now PASOS is led by people of color completely. Fantastic team of statewide community health workers. They don't need me. So I stepped away and started the Center for Community Health Alignment about 2 years ago. But our goal now is to really support the community health worker workforce and growing and thriving and being able to become sustainable and really grow in our state based on best practices, and also to partner with community health workers and other community leaders to, again, show how and develop processes so that these ideas and these leaders can really help drive change within their own communities. And one of the things that we do, and we've done from day one, is that everything that we do, every product that we develop, every best practice, every training, we have a group of community health worker experts from the communities across South Carolina called community health worker ambassadors. And everything that we do, we get their input on, because they're the ones that know. They're the ones that are in these communities that are supporting communities every single day. So one of our community health worker ambassadors is here with me today, Romaine Stevens. And she is a fantastic long-term community health worker that's been doing this work in the field. And I'd love for y'all to hear from her.
Yeah, so that's a perfect segue to Ms. Stevens, Romaine. Thank you for joining us. And, I'm curious about your personal journey, how you ended up doing this work and what drove you to do what you do.
Well, thank you for having me. I am so excited to be here. I can't even follow Julie because she is a pioneer in her own right. But what started me on this journey is that I started working with babies and moms. And one of the things that I found when working with the moms that I was servicing was that they did not have an advocate for them. They didn't have someone that could help them understand what they were getting from their healthcare providers. So they would go to the provider, and the provider would feel frustrated, like, oh, they just want to be sick, or they just don't want to feel better. They don't want to. And listening to the client, they just didn't understand what they were being asked for. They didn't understand what the medicine was and why they were taking it, and that the side effects from the medicine may happen, but that was all part of it. And so what I wanted to do was improve the health outcome. I wanted them to understand what the doctor was saying and why they should take their medicine, why they should know what their blood pressure is, why that's important. I mean, it's your own body, but you should know what they know.
That's the context, and connecting that context is key, right?
And so the good thing about what I was able to do working through South Carolina Office of Rural Health Family Solutions was that they already had a multidisciplinary team established where they had a set of providers where they brought the doctors in, and they would talk to the doctors. They would bring in social workers, community health workers, and they would have a discussion. So they would have the doctor, they would have the community health workers, and they would talk about the clients. So now when the doctor goes back to deal with the client, they had a better understanding of what was going on in the home.
Right.
Well,
that full context.
Full.
Right.
So, for example, one of the young ladies, she was missing her appointments, and they was getting ready to discharge her from the practice. So they didn't know that she was being abused at home, that she didn't have a job, she didn't have transportation to get to the appointment, and it wasn't that she just didn't want to come, but she was being abused, and she had some other issues that was preventing her from coming.
Significant barriers to coming.
And that kind of helped them to understand and to be a little more lenient with that particular client. So a lot of different things brought me into it, but to see a mom have a healthy outcome means everything to me. So and to see women go their whole 9 months and have a baby that's not alive, it just is just depressing. And so I don't want those women to experience that. If there's something I can do with the education that I have and the relationship that I have with the provider to bridge that gap, to make sure that these babies come out healthy, these moms are healthy, then that's what I want to be able to do. So that's what brought me into it, and that's what thrives and pushes me to keep going with the work that I do.
Yeah, that sounds great. So you work for the State Office of Rural Health?
The South Carolina Office of Rural Health Family Solutions.
So you work for them. How do you get in the system? How do you connect with a mom, with a pregnant woman, with a healthcare provider? How does that work? Because it sounds complicated.
It might be complicated, but I think the majority part of it is, like Julie just said, knowing what's in your area, building those relationships with the providers. So going out, finding who these ladies are going to, who their doctors are. Who do you go to? This is your doctor. Let's get a relationship with that doctor. Going to that practice, establishing a relationship with the practice to see if they would be willing to assist in the mission. We also get our referrals from DHEC. We get it from word of mouth. We get it from the providers that we establish those relationships with. We get it from anybody that'll listen. Anyone that will.
So anybody can call in.
Anyone can call in. They don't have to have any particular income guideline to get services. They just have to be pregnant. And so that's where we get the majority of our referrals from.
So, a wonkish question, but how is that funded? How is that a sustainable program here in the state?
So we get funding from HRSA.
HRSA.
I think I'm saying
Health
right.
Resources Services Administration, for those out there. Yeah.
So it's through Healthy Start. So we're under the South Carolina Office of Rural Health, but they got a grant from Healthy Start. So it's grant funded for a period of years.
Okay. And so with that funding, they employ folks like yourself to go out there and connect with doctors, connect with women, and improve outcomes.
And I'll say that program has significant outcomes.
Sure.
So Healthy
Sounds
Start.
like it, just listening to that.
Yeah, and she's being humble. But that program works in rural counties of South Carolina, some of the most under-resourced communities that face poverty, that face access issues, where hospitals have been closed down, where they struggle to even find OBs during pregnancy. And yet, because of the work that they're doing, the infant mortality rate, which in our state is very inequitable, because for African American women across the income spectrum, it's much higher than any other group. Yet, where they're working with some of the most at-risk families in our state, their infant mortality is like 4 points lower than the rest of the states for that demographic. And so, you know, the work that they're doing, again, with this very needy population is tremendous. And part of it, I'd love to hear you say more, Romaine, about some of the social issues you guys are addressing, because a lot of folks may think that healthy pregnancies are about clinical care, right? Like prenatal care, access to an OB, and that's all you need and you're good. But you brought up that, you know, moms, that mom that you were talking about that had, that was facing domestic violence. What a lot of folks don't realize is that sometimes it's the social things people are facing, or, you know, economic issues or mental health issues that people are facing that really affect their ability to be healthy. So what are some of the other things that you see your moms and families facing that affect their pregnancies and their birth outcomes that, like, you know, everybody doesn't always know about, right?
And for those on the podcast, she is shaking her head and just because I'm sure she's overwhelmed with the issues.
No, just thinking, oh Lord, just thinking about what they go through. I'm just going to give some examples of what I've seen.
That'd be great,
I've been in homes where one particular lady, she was bipolar schizophrenic. And I went in and she was talking fine at one moment. Hey, how you doing? And, you know, I just, like, in an instant. And so with that one particular lady, she was being abused. Like, her husband was abusing her. And not only was he abusing her, he was abusing her mom. And she didn't understand what was going on, why he was doing what he was doing. He would make her sleep on the floor, wouldn't let her eat. She lost like 20 pounds within 3 months of me knowing her, because he was starving her, and she did not think that what she was enduring was cruel and unusual, like, punishment. And she didn't have any running water. She would use the bathroom in a bucket and throw it out the window, like. And so she's pregnant, and she's trying to have a healthy outcome. She doesn't understand what's going on. So when she goes to the doctor, the doctor really wasn't understanding what was going on with her, but we were able to bring social workers in to try to help her get services that she needed to bridge that gap. We were able to help with the domestic violence part. So it's way more than just them going to the doctor and getting that doctor appointment. They're facing other issues or not having any type of income at all, and they're on their 12th pregnancy.
Right.
What about things like you find issues of being able to get enough food during pregnancy, or healthy food, or like housing being an issue? Do you find folks that face those kind of things?
Yeah, housing. We see housing issues all the time because they are getting put out of their homes because they don't have income coming in. Or if one of the particular houses, they may have income coming in, but there's roaches and rats and ticks, like the babies are getting bit by ticks, and there's no windows, and there's no heating in the house, and there's it may be like a 2-bedroom trailer. This particular one I'm thinking about is a 2-bedroom trailer, and there's 9 people living in there with like a newborn, a 1-year-old, a 2-year-old, a 3-year-old. Like,
and so these are types of things that people that are living in situations of poverty face, and a lot of times, like, they can go into their doctor's appointment and nobody even knows about this. And so, like, what would be your role, like, with that family that you just described that's facing those housing issues and all the health stuff that's going on in that home? Like, how could you as a community health worker help that family, and then also help those clinicians understand?
Right. So with that particular family, we were able to get them connected to a resource through South Carolina State University that came in, and they could fix the house.
Nice.
And fix what they were going through as far as the physical house. There was a food bank that was able to come in and, you know, provide food for the house. So there are resources out there for them, but I don't know if they would have had any of that if not a community health worker who knew the resources could come in, or someone who had those connections with other agencies could come in and bring that to the home. So, and then like you were saying earlier, that same family, they have to travel an hour to get the prenatal care. So that's another barrier. Not only are they having issues in their home, but then they have to travel an hour. So now we have to come in and provide them education on what signs and symptoms of preterm labor, when you should go to the hospital, what to expect when you go to the hospital, because they can't just pick up and go because they don't have the ability to get there.
Significant burden, right? I'm wondering if, so it sounds like a lot of this might be occurring because there are different norms in some communities and some populations. Like you were saying, when the mother was like, well, that's not a big deal.
Right.
You know, I wonder if you are able to better overcome those hurdles than a, you know, white male physician, for example. You know, if somebody like me came in there and told them that, they'd probably brush me off. But someone from the community, like you were saying, is able to connect, and they might listen more closely because they understand you better. They're like, oh no, she understands me. And have you seen that? Have you felt that kind of experience?
I felt that, especially when it came to birth control. So when we talked to them about pregnancy spacing, let's say they're on their 6th pregnancy, and we're talking to them about birth control, they read everything on Facebook or social media, and so they believe that as law. Social media is law, and grandma is law. Those two people are law. So if grandma says, or something that they read says, they typically believe that. But when you can come in and you part of it is sharing your own experience, like you, not to the point you get too personal, but it's almost like a give and take. You have to be realistic. You have to be not so high above them, but put yourself on their level. So it's almost like sympathy and empathy. You have to feel with them. And when they know that you care, then they listen. They don't care how much you know. They don't, you could be the doctor so-and-so, they don't care how much you know. They want to know how much you care. And once you go in and you care with them and you help them to understand, I really want this for you, and I want you to want it for yourself, and help them set those goals and help them see themselves reaching those goals, then you're making an impact. Then their grandma who's in the house see that their child is changing, and grandma is now like, baby, you know, she did take her prenatal vitamins today. So grandma is excited. And so now grandma is reinforcing what we're bringing into the home. And grandma is getting on the phone because, you know, the phone still works.
Right.
This lady came to my house and she talked to my granddaughter. And now, you know, it's helping to spread, you know, the trust, and it's helping them to, by the word of mouth, well, ain't your grandbaby pregnant? You need to call that program. I don't know. They might mix the name up and mix your name up. They may call you, oh, that nurse, or they'll call you whatever they think they want to call you. But community health workers really do make a difference in that, not just for that person, but you're affecting that family, and that family is affecting the community.
And it's like you said, you just brought up, I mean, that was just a perfect example, because let's say that you as a white male doctor or somebody, or me as a white public health, person,
right,
went into that family. I can't imagine grandma being like, oh, this person came in and she got me and I'm going to refer her to your family and your grandbaby. I mean, that happens because Romaine is a person of trust and shares a background and a culture and has those skills and that empathy and that compassion and that passion to connect with that family and to build trust.
Right.
And that's where it's at. And so she's able to affect, we've heard stories already this morning about all these different changes that she's helped people make for themselves and like true, real changes.
Right.
And what I'm understanding and hearing as well is that like all of these realities, she's able to translate that and share with the clinicians and medical team and help them be like, oh, you said one time, that the doctor had more patience with this patient and said, okay, I'm gonna treat him with a little bit more, patience and understanding because I didn't know this was going on in their home and in their community, right? So she's able to like kind of help both sides understand each other and then make changes that affect not just that individual but that whole community.
Right. And none of that would have happened if we didn't have a CHW going to the home, going to the context and making those connections.
Yeah.
So I'm curious, here we are, it's middle of January 2021, light emerging at the end of the tunnel of this pandemic. But I'm curious, especially Romaine, what you've seen out in your communities among your patients and folks who are impacted by COVID. What do you think is next? What do we need? What can we do next to help elevate these communities, these folks who are frankly being left behind in, COVID impact interventions? We were just talking before we got on here about the lack of vaccines out in these underserved communities. What have you seen and what do you think we can do next to help out?
Honestly, everyone that I know has had someone die from COVID. And for me, that's so mind-boggling because you think about everyone that you know. Everyone that I know has someone that died from COVID.
And that's definitely not my context. And to give some credence to that, I know a handful of people who have had it. I don't know anyone who has passed from it.
Yeah,
and so that's very sobering.
Right, and not even just not just the clients, but I'm like in my family, at my job, like. So being that I don't know anyone being offered the vaccine. I don't know anyone that took the vaccine.
Right.
You're my first.
Right.
So how it's going to change, I don't know, because if no one knows someone, because that's pretty much back again, grandma don't know no one. Grandma didn't say, oh, I know Johnny, and Johnny took it and Johnny's okay. That conversation is not being had, so it's like, I don't know where it's going to go.
That is a very valid answer, because I think throughout this, we don't have any idea. So many times we don't know. I'm curious, though, it sounds like your impression is that even if offered, let's say we wave the magic wand and get it out there, do you think people would be reluctant to go get it initially?
I know people would be reluctant to go get it.
So majority?
I would say the majority.
Right.
I would say like 90%.
Okay. So how do we move the needle on that? I know you're talking about grandma, or the doctor saying, do you feel like CHWs would have a good influence?
I think CHW is the answer. Yeah. If I could ring a bell, ding, 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 yay! I think CHWs would be the magic pill, if you could give a magic pill to answer it all. And not because I am a CHW, but because of what they do. They're in the community. And if the CHW that they trust, it takes a level of trust to let somebody in your home. Like, I don't know about you, but I don't just let people in my house.
Right.
So to let someone in your home on a consistent basis or come into that space, you already have trust, to there. So if the CHW goes in and they have taken it, then they're like, well, why you took? They're gonna interview you. Like, why did you take it? What happened? How you feel? So you're gonna have to go through the interview process with them. Then that'll get those wheels turning. But I think it would take CHWs actually doing it and showing them. Just that the funding, part, because for us, we're grant funded, and if the grant isn't there, then we don't get to make those changes.
Sure.
Or for people to really validate what we do, because some people still don't know what a CHW is. They're like, oh, what do you do? Oh, I'm a teacher. What do you do? I'm a doctor. What do you do? I'm a CHW. You're a what?
Yeah.
Oh, I'm a community health worker. What's that? They still don't understand. So even when you go into those providers or those systems to make those changes, and you tell them who you are, they don't know who you are or what you can do for them. So that part still needs to be discussed to get the word out.
So you're largely dependent upon these Healthy Start funds. I'm curious. I'm assuming those are not necessarily set in stone, so we have to advocate for them to be renewed annually, biannually.
I think they have to submit a grant every year, like parts of the grant every year, but the duration is for like 3 years, 3 to 4 years.
And I would assume, Julie, I think you mentioned earlier that there's some really good outcomes from this. I'm assuming you guys are tracking outcomes and return on investment and all these kinds of things to help make the case of why this should be continued to be supported, right?
Yeah, and I think that's a really important point. This is not something that just feels good, right? This is, it's not something that's like needs to be here today and gone tomorrow. What community health workers can do is so powerful. But not only does it make the patient, feel better and make better decisions and provide that support, all of which are key, but it actually results in powerful, empirical, proven outcomes. So here in our country, we've seen community health workers really become part of the system starting back in the 1960s. In the two populations where it became evident that community health workers were so key were the Indian Health Services working with the Native American population, because you can imagine white doctors going into Native American reservations, knocking on doors or trying to get people to take medicines, and the communities were like, you don't get us, we don't trust you. We had a history of y'all mistreating us forever. So we're not going to listen to what you say. So they hired what they call community health representatives, which is the term in the Native American communities, who were from that community to be bridges, to be emissaries, to help bridge that gap and help both sides understand each other. The other population was the migrant population. Again, different culture, trust barriers, access issues. And so people from within that community helped migrant populations understand and helped the health system understand the folks who were part of that community, right? And what their desires were. So since then, and even more over the last 10 years or so, because community health workers were named in the Affordable Care Act as an important part of addressing population and community health, we've been collecting outcomes. And there now is empirical evidence, randomized controlled trials, well-funded studies. The CDC, Centers for Disease Control and Prevention, have named community health workers as an evidence-based practice to address and prevent chronic disease, maternal child health, pediatric asthma, keep people out of emergency rooms, you name it. There's evidence to show that this model works. And it works as part of a health team, part of a healthcare or public health community-based team to support folks holistically in being healthier and understanding the system and making decisions and advocating for themselves and for their communities, and even working at a system level to make changes so that communities as a whole can be healthy.
And I think that's very key. And I know you guys have both brought this up very well, and at our center we're starting to pivot and focus more on this, but how do we bridge that gap between individuals and communities and the healthcare system, because they all go so hand in hand, and for too long in this country we've thought of an individual going to a doctor to address their needs, and especially as Romaine has pointed out so eloquently, it's far more complex than that. So I think that's very important.
And I think back to that funding question, it's essential. So as Romaine mentioned, her work right now is, funded maybe for a couple more years.
Right.
But we've heard the impact that she has on so many families and on that community as a whole, and her whole team has on that very population that needs it the most, right? But in a couple years, if the funding is not renewed, that goes away.
Right.
So everybody loses.
Right.
That child, that grandma, her. The clinicians that are dependent on that understanding and that comprehension, right? So, as one of our allied partners says, we need to get to the point where community health workers are the norm. So, if you go to a doctor, you're going to get a nurse, right? You need to know if you're in a position of vulnerability or a position where you've got risk factors, you need to know that you can get a community health worker. It needs to be guaranteed by our system, just a regular part of the system, that you've got these experts, these professionals who are experts in not only health and health promotion and things like infant health and lactation and and mental health and all the things that somebody like Romaine can do. They're experts in their communities. They're experts in trust building. They're experts in being able to sit with this family and say, hey, I got you. I'm here with you. I can help you achieve your goals, and I can do it in a way that's not threatening and that makes sense to you. And that needs to be sustained by our health system so that we can make sure that these folks who are in these kind of vulnerable places get the help that they need in a way that makes sense for them.
Right. CHWs, some people would ask, why are they needed? We already have nurses, we have social workers, we have healthcare teams. What does a CHW bring to the table, to the healthcare system?
And I'm glad you asked that question, because that question was asked to me as well. I was in an appointment with one of my young ladies and her doctor, and he was like, so what is your role? Like, how are you supposed to help her any better than I am? And he blatantly just said it, didn't sugarcoat it. And my response was, my role here would be to help her understand what you're doing better. You could have a car, and it could be a nice car, but if you don't know, and you could give her the keys to the car, like, this is your medicine, give her the keys. But if she don't know how to open the car door and put the key in the ignition and turn the key and put it in park,
or doesn't have money for gas,
I don't have money for gas,
inflate the tires.
Then you doing your job as best as you're doing your job, and her at doing her job the best she knows, the car's just gonna sit there. So I think that our role is different than their role, but it's almost like an additive to their role. It enhances their role.
We always talk a lot about barriers, shortcomings, gaps within rural areas, and a big reason we're doing this podcast is to try to bring out the great things about rural. So, from both of your perspectives, especially, Romaine, who are out in the community, tell me what is great about rural South Carolina right now.
What's great about rural South Carolina is that it's thriving and it has resiliency to want to grow. It's looking for opportunities where it can expand and bring in access to different things like telehealth. And so that's the good thing about rural from my perspective, that they're willing to grow and expand and learn and do more.
And more philosophically, this is a pet project of mine, but how do you define rural itself? Like, how do you know you're in a rural place, or how do you tell someone from New York City what rural South Carolina is?
I would just put them in the car with me and take them home.
Right.
When we go down the road and you went 7 miles and you didn't see a gas station, you didn't see a convenience store, didn't see a stoplight, you don't see anything but fields. You see fields, more fields, trees, more trees.
Right.
I would describe rural as just access to buildings. Like, some people can take for granted they can go out and go a mile and they can get to a fast food place, or they can get to a grocery store. Oh no. Yeah. You're going to have to travel to get some bananas in rural. You're going to have to travel to get to a gas station. The things that people take for granted, my son, he now lives someplace else other than South Carolina, and he's like, Mom, I can go down the street and I can go to Barnes and Noble. We don't have that.
Right.
The little things. So rural, even at the doctor, you want to go to a heart doctor and you having heart issues, can't find. You're gonna have to travel to get to a doctor. So rural is just that. It's not a lot going on in rural.
Yeah, which is not always a negative thing.
It's not always a negative thing unless you want a banana.
Unless you really want something, right? And then it's a barrier, but...
Yeah.
When I think about rural, I think about people and friendliness. And I guess, like, when I spend time in a rural area, my parents live in a rural area, you know, when I'm visiting and spending time with community health workers in rural areas, just the friendliness of the people and that a little bit slower pace to, like, have conversations with people. Whereas sometimes, you know, in urban areas, because we have so many buildings and so many cars, we're rushing from one place and rushing to the next. And I'm not saying that it's slow by any means in rural, but it just feels like there's a little bit more time to build relationship. You know, especially when there is a trust factor, which is why, you know, again, coming back to community health workers, it's so key because of access issues, because of not having everything around the corner that somebody might need. It's so much more important to build on that power of relationships and power of people, and that people-to-people connection in rural South Carolina.
Well, thank you both for joining me. This has been a wonderful conversation, and listening to your stories, Romaine, have been sobering and enlightening, and hopefully that will encourage folks to advocate for CHWs across the state and continue to see that progress here. I think that's wonderful. So that's all for today. Please check out our show notes. We'll put links in there for both organizations and pertinent links in there, such as our website. We have a dashboard on there, for example, that has travel times for providers like OBGYNs. So that would be helpful for some more context. Stay tuned for more episodes coming out soon. If you like what you've heard today, please head over to iTunes and leave us a 5-star rating, minimum. And if you have ideas for other guests you'd like to hear on our show, please reach out and let us know. And that's all for today.
Thanks for listening to the Growing Rural podcast. If you found the content valuable, please leave a rating on iTunes or Spotify so others can find us. For more information, please visit our website at sc.edu/rural healthcare or follow us on Twitter at SC_CRPH. This was recorded at the University of South Carolina School of Medicine in Columbia. It is edited and produced by Sean Riffle. Y'all take care.